关掉，再重开一次。这个好。So the first patient is a 75-year-old male who has a history of hyperurothelial carcinoma and received radical cystectomy and with a neobladder reconstruction. So for the neobladder reconstruction, usually the clinician will use a segment of ileum, a small bowel, to do what we call ileocondyl for the neobladder. So in this type of urine specimen, first of all, because the patient had a history of hyperurothelial carcinoma, so it is possible that they will have other second primaries throughout the entire urinary tract, including the upper urinary tract. So we still need to follow the urines regularly to exclude the possibility of second primary. So for this type of specimen, usually in the urine we will see this type of cell that is actually the degenerated intestinal epithelial cell. So it's a degenerated mucinous epithelial cells. So this is typical that we will see. And this is actually the normal cells in the ileocondyl urine. So for this type of urine specimen, we still need to screen for the high NC ratio hyperchromatic, just high-grade urothelial carcinoma looking cells. So in addition to these degenerated individual mucocytes, so you also see some glandular type of arrangement, but also highly degenerative. So these are all derived from the intestinal epithelium. Additionally, we can see degenerated tall columnar cells. So this is also coming from the neobladder, the ileocondyl. So in this specimen, we have these relatively unusual cells that is actually derived from the neobladder, and we do not see any high-grade urothelial carcinoma cell. So for this specimen, we will call this negative. So this is a 86-year-old male, female, who came to our emergency department because of shortness of breath. We've seen the specimen yesterday. So in our ER, she was found to have massive ascites, so we perform ascites taping. So for this, pleural effusion, massive pleural effusion. So we perform pleural effusion taping, and for this specimen, we see individual cells with low NC ratio, relatively bland looking. However, if we compare to the size of the lymphocyte, these are just very big, too big. And the nuclei are really prominent. So these are actually poorly differentiated adenocarcinoma, and majority of the cells are actually tumor cells. So there is very, very scant benign component in these specimens. That's why we do not see a very apparent two-cell population, because all the cell, most of the cell were tumor cells. So this is the cell block preparation, and because this is a new patient, we will do TTF1, and for TTF1, almost every cell is positive. So this is compatible with lung primary. So it is relatively rare to have initial presentation of lung adenocarcinoma in these individual poorly differentiated form. I would say about 5% of our cases initially diagnosis would show no glandular arrangement, but only this type of single cells. So this is more commonly to be present in the recurrence, like after treatment setting, but rarely we will see these in the primary setting. So these need to be be careful because on low power you might miss the lesion because just because everything is the cancer cell, so it looks relatively like a bland looking because you do not see the typical second population, two cell population. So the next specimen is also relatively uncommon. This is coming from a 58-year-old male, and he, after the image analysis, he was found to have a secant tumor and with peritoneal seeding. So this specimen was obtained during the operation for the secant excision. So during the surgery, surgeon actually find out that the lesion is at the appendix. So rarely we will see appendicemal tumor and with peritoneal spreading. This is one of the rare scenarios. So if the tumor are low grade and produce a lot of mucin, sometimes we will see an unusual presentation that we call pseudomyxoma peritonei, that in the washing cytology specimen we will see mostly extracellular mucin. In this specimen, we see very scattered tight aggregates of cells. Here we do see mitosis. The cytoplasm are pretty abundant. So these looks like a highly atypical glandular cells. So this looks like adenocarcinoma. Relatively unusual is that in this specimen, we have scatter of these signaling ring type of cells with abundant intracytoplasmic mucin with a little bit oranginophilic staining. So despite the relatively bland looking appearance, these are actually cancer cells. And they looks very bland looking because the nucleus are very, very small. But because of the cytoplasm, you see these oranginophilic, like a foamy material. These are actually adenocarcinoma. So it looks a little bit like signaling ring cells, but it actually doesn't form a good signaling ring morphology. But you can appreciate that the cytoplasmic mucin pushing the very small nucleus away. So these are adenocarcinoma. So if we take a look of the cell block preparation, we can actually see like aggregates of these signaling type of cell and with abundant like a mucinous cytoplasm. In the background, it also shows a little bit of extracellular mucin. But unlike pseudomyxoma peritonei, usually it's derived from what we call a low-grade appendicemal mucinous neoplasm. And this looks more like a invasive type of adenocarcinoma. Instead of like a pseudomyxoma peritonei, there usually we only see the mucin, but not the cells. So these cells are actually malignant despite a very bland looking appearance. So we will call this positive for adenocarcinoma. So next, this is a peritoneal washing specimen obtained during the total hysterectomy for a 35-year-old female with endometrial cancer. So very young. So on low power, we can tell that this is derived from the peritoneal washing because we see these large cohesive fragments of mesothelial cells in these nice honeycombing arrangement. So usually for the ascites specimen, you won't see these larger cells. It must be derived from a mechanical force. So this is a washing cytology specimen. So in the washing cytology specimen, we must not over-interpret the aggregates of these cells. So here we have some other like a bigger cluster of cells. However, this looks a little bit more three-dimensional. However, when you take a look of the nucleus does not show any differences comparing to these like a flattened cells. So despite these like a relatively three-dimensional appearance and even a little bit like a calcification in the center, the cellular morphology, it doesn't show like a obvious atypia, and it looks very similar to these mesothelial cells, benign looking mesothelial cells. So we actually do not see like a tumor component here. Occasionally for the washing cytology specimen, we will encounter, so again you see this is relatively uniform, and we will occasionally see some structure looks like this. So we have a hyaline globule as a globular shape arrangement. So these are also derived from the washing mechanical force. So basically, I think in this specimen, it's relatively plain looking. And then here we start to see the tumor cells. So for the endometrial cancer, it is relatively rare that it will go out of the uterus. So there were some mechanisms that can be spreading. The most rare type is direct invasion through the myometrium, but the most common type is actually because of the surgical manipulation. The tumor cell might be floating from the fallopian tube and leak out through the fimbrilla to the washing cytology. So here we see much more obvious these type of polymorphism, as well as these individual cell looks like a karyoresis, or what we called the inflammatory cell going inside the epithelial cluster that we call these phagocytosis. So these patterns are actually more typical for the endometrium type, typical endometrium type adenocarcinoma. So in this specimen, there were some cluster relatively plain looking. These are not tumor cells, but the tumor cells are actually forming also similar cluster, but with a definite more prominent nuclear atypia and some phagocytosis pattern. So these are the true tumor cell. So if you compare to the appearance, so the chromatin pattern here is more vesicular. You see chromatin, vesicular chromatin and some small nucleoli. The cell do show some sort of polymorphism. And if you go back to the other cluster, such as this one, these all looks very uniform. And the cell, the chromatin pattern, you see very delicate, evenly distributed chromatin. So these looks relatively benign. So these are actually mesothelial cell. So we need to highlight the true tumor cell cluster for the diagnosis. So next, let's move to the fine needle aspiration. First, thyroid. So thyroid is relatively common, and we've seen similar specimen from time to time. This is a relatively pulsy cellular specimen, but in the background we don't see colloid. So on low power, we start to see, okay, this looks like a decapitated papilla. So you see the luminal border, and on one side it is blunted. So this looks like a papillary structure. And the cell looks atypical. But if we want to appreciate the nuclear detail, we will go to the more flattened area. So in this area, you see the cell show vesicular like a powdery chromatin pattern, elongated sun grooves, and we also see pseudo inclusion here and there. So this is positive for papillary thyroid carcinoma. So despite the low cellularity, the background is very typical as lack of colloid, and the cell aggregate is also typical. And we also have typical architectural pattern. So this is positive for papillary thyroid carcinoma. So the next specimen is a bone aspiration specimen coming from a 33-year-old male, so relatively young. So this is a direct smear. So for this direct smear, we start to see a lot of these multinucleated strand cells. So remember yesterday we see a subacute thyroiditis with strand cells. So in this bone aspiration specimen, we also see a lot of strand cells. So majority of these cellular components are actually strand cells. So for this type of specimen in the bone, we would report it as negative for malignancy, strand cell rich lesion. So there are several possibilities for the strand cell rich lesion, including ABC aneurysmal bone cyst, including strand cell tumor of bone. Sometimes even chondroblastoma, it will show prominent strand cell. So we will call this strand cell rich lesion, and it's likely a strand cell tumor of bone based on the image study. So we can say that it's suggestive of a strand cell tumor of bone, but they still need to confirm by the biopsy specimen. So here we see just abundance of strand cell in these specimen. So this is a lung aspiration. It's an imprint cytology. So for the imprint cytology, usually we will have relatively scant cell with prominent drying artifact. So for this case, we see prominent drying artifact and the smearing artifact. So you see the nucleus of these cells are all like a crashed, so it's very difficult to see through. However, if we go to the focal area, relatively preserved cell, you see big cell with polymorphism with high NC ratio, and the chromatin pattern is coarsely granular. So this looks abnormal. And in this cell, we also see a single nuclei, very prominent nuclei. So this looks abnormal. So in the lung pathology, the major distinction that we need to make is that whether this is a small cell carcinoma or it is a non-small cell carcinoma. So for the small cell carcinoma, it is quite common that you can see this crushing artifact because the cytoplasm is very scant and the cell membranes are very fragile. However, if you take a look of the morphological pattern, the chromatin pattern is relatively more coarsely granular instead of the salt and pepper pattern. And we do see individual cells with prominent nucleoli. Plus, the size of the nucleus is quite big. It's for the small cell carcinoma, the nuclear size is increased, but usually is not as big as what we see here. So despite the low power appearance, striking crushing artifact, some of the cell does show a little bit molding type of pattern, but it does not look very much like a small cell carcinoma. However, for the non-small cell carcinoma, it also does not look like a typical adenocarcinoma or a typical squamous cell carcinoma. For the squamous cell carcinoma, usually it is not easy to get crushed because the cytoplasm has keratin, and usually it's more resistant to the crushing artifact. So it does have a very strange looking, like a basaloid type of appearance, easily crash, and with these like an immature type of appearance. In a small area, you start to see a few cells showing more cytoplasm, more like a mature form of squamous cells, forming like a so-called a whore-like pattern. So this looks relatively strange. Maybe something unusual. So in the surgical specimen, they first do TTF1 and P40. So it is P40 positive and TTF1 negative. But the patient, despite the older age, he is actually a never smoker. So it is also uncommon to have squamous cell carcinoma in a never smoker. So our lung pathology do additional staining, including EB virus. So they are EBV-associated squamous cell carcinoma. It used to be called LELC, lymphoepithelial carcinoma of lung. But nowadays there are some subtype that does not show prominent lymphocytic infiltration. And they also do a NOT immunohistochemistry. So these turn out to be a NOT carcinoma of the lung. So this is very rare. But the morphological pattern, we can appreciate that it has an immature, like a basaloid type of appearance, as well as what we call abrupt, like a maturation, abrupt keratinization. So you can actually see like a similar feature over here and there. So this is an unusual case of a non-small cell carcinoma. Cytologically, it looks a little bit like small cell carcinoma, but there are some differences. And it is proved to be a not carcinoma. So the next specimen is Pap smear, the final specimen, coming from a 60-year-old female. So on low power, we see a lot of inflammatory debris, sort of like a little bit like necrosis pattern, and we do not see superficial cell, intermediate cell. So this is a problematic smear. It is not a normal smear. So when we screen this type of smear, we need to be really, really careful. Because in the worst scenario, these can be the presentation of an invasive cancer. So throughout the smear, we go to medium power. It's relatively indistinct, so we see a lot of debris material, some with interesting spindle shape, but the majority of them were PMN, like a necrotic, like an inflammatory type of debris pattern. So in this type of smear, you really need to be careful to screen for the true epithelial cell. So sometimes these epithelial cells will show striking degeneration, but here you can appreciate these are squamous cell and sort of like showing individual apoptosis pattern. So the lesional cell is very, very scant in this specimen. Yeah, but the background, the overall background appearance is typical for invasive cancer. And then you start to see these abnormal spindle cell. You see the tumor necrosis type of pattern. So these are tumor diastasis, and you have like a more well-preserved aggregates of hyperchromatic, high NC ratio cells. So this is squamous cell carcinoma. So just this month, diagnosed 4 cases. It's almost like our heaven years, like a month. So the patient already also received the biopsy, and the biopsy does show feature of squamous cell carcinoma. So again, you can see these epithelial cell was hiding inside these necrotic debris. So so this is a good smear, especially for our trainee. For this, at the beginning of your screening career, you need to pay a lot of attention on these type of smear. So on low power, everything looks inflammatory. You just need to go to high power to find these. These are tumor cell with necrosis, so these are tumor diastasis, and likely squamous cell because of the spindle shape, and some cytoplasm also maintain this keratinization. And here you see more like a preserved nuclear with hyperchromasia and high NC ratio. So these are all cancer cells. So just need to. So these are tumor necrosis with necrotic keratin debris. So this is not an easy smear if you don't have experience, but just on low power view, this is abnormal. So you really need to go to high power to have more like a careful screen. So necrotic keratin cells, so tumor cell. So this is positive for squamous cell carcinoma. Okay, that's for all the case today.